The next speaker is Ben Jonker, who is going to talk to us about treatment of trigeminal neuralgia by radiosurgery or MVD, a systematic review. Ben.
Thanks very much, Chris, and thanks for having me here. Just got to work out which one do you advance the slides with, the top button. Okay, yeah, good. So yeah, thanks everyone. What I wanted to talk about was a meta-analysis and systematic review that we did a few years ago. I did it with someone who at the time was a medical student called Victor Liu, who's now a resident in Miami. He's an Australian medical student, but moved over to the US for some research and then subsequently training. This is kind of the usual problem. I don't know if we've got sound here. Can we play the video? If it doesn't work, it doesn't matter. Oh yeah, that's all right. Anyway, this is a typical patient. You can see he was having attacks of his right-sided trigeminal neuralgia in the office. And I don't know if this next video will play either, but oh yeah, it might. Is it going to go? Let me just go back one. Anyway, look, the problem is that sometimes people come along with a beautiful SCA compression of their trigeminal nerve and they say, look, I just don't want to take any time off work and can I do radiosurgery? And when I first started in practice and even at the end of my residency, I kind of wasn't sure where radiosurgery should fit in the management of trigeminal neuralgia. I'm from Sydney in Australia, and that's a gratuitous shot of our Harbour Bridge. When I went on fellowship in 2009, there was no neurosurgeon in Australia who was doing any radiosurgery at all. We had no gamma knife, no cyber knife in the country at the time. In Sydney, we had one experienced radiation oncologist who did radiosurgery. And I asked him, I remember in 2008, in my final year of training, I said to him, how do you decide which patients you give radiosurgery to? And he said to me, I'm not a neurologist. If they're sent to me with trigeminal neuralgia, I give them radiosurgery. So there was very little sort of selection process going on for those patients. And of course, I knew that if you only end up sending the multiple failure facial pain patients who've already seen the neurosurgeons and had several procedures off to the radiation oncologist and he treats them in every single case, it's not surprising if the outcomes aren't going to be spectacular. And so I wasn't sure if the outcomes I'd seen were unimpressive because of patient selection versus the technique. A few years after I got back to Australia, I did a survey of, at the time, the 226 neurosurgeons in Australia, of which 106 responded, which was a reasonable response rate because many of the others probably didn't do any trigeminal neuralgia surgery or have any involvement with it. And interestingly, at that time in Australia, only 3 out of 10 neurosurgeons who responded had ever referred a patient for radiosurgery. And I wondered about, it'd be good if there was a randomized controlled trial of radiosurgery. And you can see I also surveyed a similar number of neurologists. And actually, people were quite open to the idea of a randomized controlled trial of a percutaneous technique versus radiosurgery, which probably makes a lot of sense. But when it came to MVD versus radiosurgery, there was this big disparity between the neurosurgeons and the neurologists, which is that the neurosurgeons were not open. And I personally think quite appropriately, they didn't feel that there was an equipoise between these two specific techniques. The neurologists, I think you have to take with a grain of salt because they probably don't understand the reasons why you would choose one thing over another. So in the absence of randomized data, one option is to do a systematic review. The thing about this systematic review, which perhaps differs from some of the other ones that have been shown that have larger numbers of patients, is that we wanted to do a systematic review that looked at studies in the literature that involved comparisons between the two techniques at the single institutions that they were each published at. So not just here's a series of MVDs and here's a series of radiosurgery patients, but here's our patients and we did MVD on this bunch of patients and we did radiosurgery on this bunch of patients and here's how they did following that. And some of them have been prospective, a couple of them anyway. So it was patients with medically refractive trigeminal neuralgia. The intervention was stereotactic radiosurgery. The comparator was microvascular decompression. And the outcome was pain freedom and complications, conducted according to the PRISMA guidelines, and search strategy we published in the published version of this a few years ago. It is a bit old now, is what I was going to originally speak on at MVD 2020. So to be included, the patients had a confirmed clinical diagnosis of medically refractive trigeminal neuralgia. It had to be reported in a comparative study comparing the two techniques. Patients were over 18. Ignore the words short-term and long-term outcomes, but basically the initial outcome from surgery versus the final follow-up outcome were looked at. Pain freedom was inferred by a BNI score of 1 or 2 in the end in this systematic review. And we also separated studies that looked at, and this is coming back to my point about my experience of seeing radiosurgery as being this sort of end of the line, drain the bottom of the bathtub kind of approach to radiosurgery. So we looked at studies that were treating patients as their first primary treatment, as well as the others, but we separated it out. We excluded studies with unclear outcome measures where other surgical techniques were incorporated in patients with multiple sclerosis, and we excluded abstracts, case reports, conference presentations, and expert opinion. The literature search identified 532 records from the database, and you can see once we sort of heavily edited it down to suitable studies, there was 13 suitable studies that had quantitative data that we could use for that comparison. And this is a list of those studies there. You can see that actually 8 of the 13 had patients that were having their first time treatment for trigeminal neuralgia, which was useful. There was 1,211 patients in total. In the end, these studies showed just over half were treated with SRS and just under half with MVD. And interestingly, they actually were of similar ages, despite being a prospective non-randomized kind of data. Proportion of males was similar between groups. So what are the results? Well, pain freedom was achieved in the first 3 months after surgery in 65.3% of patients undergoing SRS and in 89.3% of patients undergoing MVD. And you can see the summary of effect by the black diamonds that are down the bottom here. This is the total summary for both the primary only and for the studies that involved a mix of patients. And you can see clearly there was a highly significant effect with MVD favoured over radiosurgery. What about further along with longer term follow-up? Well, so the average follow-up was only short, it was less than 3 years, as you can see. But the SRS patients, only 44% were pain-free at final follow-up, and 68% of the MVD patients were pain-free at final follow-up, again leading to a highly statistically significant odds of pain freedom being better after MVD than SRS. What about postoperative complications? And for this part, we excluded facial dysesthesia and numbness since they are part of the potential mechanism and effect of radiosurgery, and we just deal with that separately. So essentially, there were no patients who had SRS who had any significant complication, at least in this series, outside of the patients with the facial sensory symptoms. There were 11.6% of patients that did have some form of complication after MVD, with CSF leak being the most common individual complications, but others including wound infection, hearing loss, facial palsy, and diplopia, and so forth. So what about facial numbness and dysesthesia? Well, this sort of looks a bit funny at first. Essentially what we can see is that your odds ratio for your risk of having facial numbness and dysesthesia is significantly higher after SRS than after MVD. But interestingly, when you looked at the non-primary studies, they kind of, I'll go back one, they overlap the line of no effect. So what does this mean? Does this mean that gamma knife in redo patients doesn't induce facial dysesthesias or sensory changes? No, of course not. What it means is that unlike Professor Krause's excellent series, many of the non-primary MVD surgeries will induce some facial sensory complications, and that's why you couldn't see the difference in those those groups. What about the need for a subsequent procedure? Well, I think that the numbers are really too small, and in particular, the follow-up is too small. But essentially, 17% of the SRS patients went on to have a subsequent procedure. 10% of the MVD patients went on to have a subsequent procedure, but it didn't reach significance quite. So what are the limitations? Well, follow-up, of course, is much better analysed by Kaplan-Meier survivorship, not by a single time point in the future. But that's difficult to do, both from the way that the data is presented in the literature and also from the actual meta-analytical methods that you can use. We didn't consider other ablative techniques. This was purely MVD versus SRS. They're all obviously observational cohorts only. And so my conclusions are that, and none of this is going to be the least controversial talk in the whole meeting, I'm sure, but MVD remains more effective than SRS at both initial and last follow-up in providing pain relief from trigeminal neuralgia. Facial sensory complications are more common with SRS, especially in the surgically naive patients. Other more serious complications are rare or non-existent with radiosurgery, and there's a trend towards increased reoperation in those undergoing SRS compared with MVD, even with a follow-up period that was kind of less than 3 years. And I'm sure that that would be only extended further on. So thank you.
Online question, is that the one from Jason Schwab?
Yes, he also has his hand up if you want me to.
Yeah, let him go.
Hey, this is Jason Schwab. I hope you can hear me. I'm curious to see, you have this very nice data. I'm wondering if the opinions of the neurologists and neurosurgeons in Australia has actually changed when presented with these data or not. They might not.
Yeah, it's a good question. And to be honest, it might have changed somewhat anyway, because it's a while since I did that data. The bigger part of that data that I didn't present was I was trying to look and see where people feel that there is equipoise between treatments, because if you're going to ever try and conduct a randomized trial, you're certainly going to fail if you don't have a group of people that believe there's some equipoise between the treatments. So.
Looks like Dr. Zimno said his hand up.
Yes, hi. Thanks for the very nice presentation. A quick question. Did you look at all dosing on the cohorts that were included, or the 80 gray at the peak of the nerve, or was it like all comers, everything together?
Yeah, thanks for that question. Yeah, this was all comers. I mean, other people a long while ago, I think Bruce Pollock did a meta-regression based on a systematic review of RCTs for trigeminal neuralgia, but based on studies of trigeminal neuralgia. But yeah, no, ours was just all comers.
Last question, Christian.
Hi, thanks for the presentation. So I'm a neurosurgeon in Quebec, and I do both. And one of the big challenge with just comparing SRS to MVD is that not only is SRS less durable, but it also has a latency. So even if you check the outcome at 3 months, many patients will not have yet responded to SRS at 3 months. Sometimes they will respond at 4 or 5, and we never treat somebody again within the first year of their treatment. So I think, and statistically, I don't know how to do that, but you need a Kaplan-Meier that goes both ways. So the response and then the recurrence, and what matters is the pain-free period. Like, it's the time that they are pain-free after SRS, and because they will always recur eventually. But comparing that in a meta-analysis is highly challenging, and probably a better metric would be pain freedom at a year, or duration of pain freedom, or something like that.
I definitely understand what you're saying, and I take that point. The problem is that trigeminal neuralgia is a condition that relapses and remits, and so you introduce a bias there, because if you didn't do anything for these patients, there's going to be a significant number of people that sometime in the next 12 months will be pain free, and so you have to, without controls, you have to just make some sort of judgment.
I do have one more question if there's time.
No time.
Okay.
Sorry. I have